frustration.
Okay, again, so now I am Feng and I am presenting the work. Pardon me for this presentation, and I hope no complaints. Okay, the idea is that we want to be very active in research and open new areas, and neuropathic pain is very important and sufferings of mankind, and millions of people worldwide they are affected. And still today we do not have any cure or good medicine for that. So working in Uppsala University, we have started this work on neuropathic pain, and this is also has related to battlefield injuries, because CNS trauma and injury can exacerbate the symptoms of neuropathic pain. So what we are doing, this is Dr. Linyuan Feng. He is in, as you can see, Norman Bethune International Peace Army Hospital in Shijiazhuang. It's a wonderful place. And we have a great cooperation with him. And normally, it is very difficult. This is imaginary picture telling that what kind of neuropathic pain. You have different kind of sensations. Stabbing, pins and needles, throbbing, burning, shooting in different parts of the body. This can occur even after injury, head injury, spinal trauma, and many other factors, even diabetic neuropathy and many other neurological diseases. But the cause and treatment is still do not well characterized. It is believed that this is a cartoon of very familiar with you, this spinal cord and supply of nerves. It is believed that when nerves are damaged, some way, these peripheral nerves, sensory and motor, then over the period it leads to a neuropathic pain. What we have done in Uppsala, this is a history of several hundred years of research in neuropathic pain with Torsten Gård at Uppsala University. And because his father was also an anesthetist, and the legend has it, maybe some of you know that, his father was giving anesthesia to the former king of Sweden at that time, and nothing was working. So the senior Mr. Torsten Gård came after half an hour and said, well, the giant slept already, and the king said, not yet. So this is true story and recorded in Swedish history of anesthetic medicine. So therefore, there is a history of neuropathic pain, and we have model to work on either sensory or motor neurons where peripheral nerves were cut, and try to study neuropathic pain. And then we combine with our friend Linyuan Feng, because he is in a military hospital and he has experience of so many soldiers complaining with neuropathic pain. So we have shown for the first time in 2006 that neuropathic pain induces blood-spinal cord barrier breakdown, because people still do not believe to this idea that pain can really induce structural changes. And so we are very happy that it was accepted in pain, and Basbom is a well-known person, the chief editor, and also the activate astrocytes. There were some papers telling microglial activation, but till that day nobody was exploring astrocytic activation. So we did that and we found. But now the question is that we have added that what will happen when people are exposed to different kinds of nanoparticles? Can it exacerbate the neuropathic pain, because we can see in hypothermia? So this is the theory. And just to let you know that the model that we are working were already in practice in our lab 1998, 2000. So if there is neuropathic pain due to diverse origin, can it be influenced? And there are so many other factors that can influence the outcome. So the protocol we use is spinal nerve lesion, and then we intoxicate it with copper and silver and aluminum nanoparticles of the same size to understand that whether it is size or it is the type of nanoparticles that matter. Survival in this case, we have a standard protocol 2, 4, 8 or 10 weeks after surgery. And I'm showing you this. These are the control, and we have studied in 3 levels of a spinal cord, T10, T12 and L5. The lesion was in L4 and L5. So And then, so these are the control, and these are albumin positive cells, hardly seen. But after, in normal animals, not intoxicated, T10 and T12 and L5, they show increase in albumin reactivity. This is 4 week. The first bar is 4 week, the second one is 8, and the third one is 10 weeks. So there is time-related increase. So there is time-related increase of albumin leakage in sections T10, 12, and L5. When we have intoxicated them with copper, you can see the pattern is same, but the magnitude is very high, except in L5 is going down. But silver has increased albumin leakage, and this is 4, 8, and 10 weeks. In all segments, 4, 8, and 10 weeks. So we learned that if there are nanoparticles in the body for 1 week, then the exacerbation of neuropathic pain in relation to blood spinal cord barrier breakdown is high. So this is the picture of, again you can see this is graphic to show you that this is silver, this is copper, and this is normal. So there are differences. Silver is more toxic in these circumstances than copper, and these are different control than normal, and copper and silver, again T10, T12, and N5. So the relationship is linear.
Eric, the same diameter, silver and copper, nanoparticles the same diameter?
Yes, 50 to 60 nanometer, and the same dose. And here is astrocytic activation. As you can see here, these are control and these are the lines graphically. You can see that this is silver, this is copper, and these are normals in different segments. T10, T12, and L5 means descending segments. Then the distortion of nerve cells was also very similar, and as you can see here that this is the silver that has maximum neuronal damage, followed by copper, and this is the normal cases. So the pattern is very similar, more albumin leakage, more neuronal damage, and astrocytic activation. But what happens to pain sensation? Everybody or clinicians know very well that the pain perception can decrease over time. And what is happening is exactly here. You can see that the same situations are there. There is no great difference in the pattern. These are the normal, these are copper and silver. Over the time, the pain perception is decreased. So they become more hypersensitive. To the morphological changes then, what we are observing, it is in line. I guess it is in a very line of the idea. This is GFAP in neuropathic pain. You can see that they are increased in all the situations. These are the normal in 3 different segments, and these are intoxicated with nanoparticles. I guess this is silver. And also, here you can see that 10 weeks of neuropathic pain, and neuropathic pain with silver, it's complete vacuolization of the spinal cord, and you hardly see any neurons in this situation. So again, the hypothesis is that there are well-known regions to treat with neurotrophic factors, because there are different schools of treatment in neuropathic pain. BDNF and GDNF were given, and even clinical trials also suggest some recovery for certain time. So therefore, we again use this cerebrolysin to test our idea that whether we are wrong, because if cerebrolysin is working in one model theoretically, and if it is good, it should work similar in another model too. So we have used cerebrolysin. This is ample and normally used in milliliter, and we have a couple of papers in traumatic injuries. So here the dose response was 2.5 milliliter per kilogram intravenously daily for 1 week, Then another was 5 milliliter per kilogram intravenously daily for 1 week. We have some variations, 1 week after lesion, 2 weeks after lesion. And what we found that in these cases, high doses are very effective and low doses are effective for shorter time. We do not know the detailed mechanisms of this. So we should study this image. So here is GFAP after cerebrolysin. This is and albumin. This is albumin and after cerebrolysin. This is GFAP, and here is albumin untreated and GFAP untreated. You can see that one can see a reduction in the expression of these two immunoglobulins. And here you can see that this is cerebrolysin in high dose is treated, GFAP again, and albumin, they are much different or much lesser than the normal situations. And the neuropathic pain is very important aspect of neuroscience research nowadays, and therefore I am happy that this kind of work is accepted in Society for Neuroscience as policy issues. As you may aware that papers or policy issues are very hard to be accepted by neuroscience, Society for Neuroscience. And again, we are invited to this meeting called ASRA, American Society of Regional Anesthesia. But this is a coincidence. When we say the word ASRA in Hindi, it means hope and shelter. So this is a very funny meeting. This is in Miami, and if people have interest in that, they should participate November 15 to 18. And we are going to talk about neuropathic pain and its modulation by nanoparticles. Also, Dr. Feng got this talk for another aspect, that how manganese can affect neuropathic pain and traumatic injuries in Society for Neuroscience. So in conclusion, what we can say that like other hyperthermia or spinal cord injury research, nanoparticles, at this time engineered nanoparticles from metals, exacerbates neuropathic pain-induced pathophysiology, and cerebrolysin therapy, depending on the dose and time and its limitation, can have some neuroprotective effects. This is Dr. Feng. He could not come here. Probably you will see him in the Society for Neuroscience. And this is the director of the hospital. She did PhD in Sweden, and this is the principal of that hospital. And this is a presentation from Dr. Feng from Bethune International Peace Hospital. I look forward to your suggestions and comments so they can forward this commentary in the comments. Thank you very much for your time. Yeah.
Obviously, it'd be another.
Yeah, well, these nanoparticles were obtained from sigma, and they characterize their diameter. And the other research we are doing, probably I will show you tomorrow, size and dose related changes, because this is very important. We have not done for this investigation, but in general I can say based on our observations that the smaller the size, it can produce more damage.
Phil, you got a question?
Well, yeah, I was just wondering about, I was trying to recall how you administer these compounds in this situation, because distribution and being able to get to the target site is a critical feature here. So how were they administered here in this situation?
Yeah, this is a very important question, and there is a lots of discussion about that, because these nanoparticles are not soluble. You can't inject them intravenously because they will, homogeneous solution is not neat. But there are so many papers they are administering intraperitoneally, and they should be suspended in any substance like quinine, so they are suspension, and they were injected intraperitoneally, and there were 5 papers to my knowledge in vivo administration published in reputed journals where they have studied that chronic exposure to these nanoparticles for 7 weeks to 6 months. And they studied distribution in mice and rat brain. And what they found, some papers are from Germany, and I think few papers also from France and Switzerland. So they showed that intraperitoneally administered nanoparticles whether they are administered with quinacti or even with saline, just a mixture, they can reach to the brain they found the traces in the brain and also other organs within 4 days. So we did not do this measurement of nanoparticles that what is the percentage they are reaching in the brain. But one thing is very simple, that the physiology or pathophysiology of these animals in which nanoparticles were given is changed. And therefore, whether it is stress caused by nanoparticles or nanoparticles induce a direct effect reaching to the brain or peripheral nerves could be responsible. At the moment, we can't say. Yes?
I was wondering, you say those metals actually are not soluble, but once you inject them intravenously, they can be ketynes. Physically, they are ketynes.
Yeah.
So I wonder if the charge, the potency of the produce the charge can cause maybe the permeability change of the vessels or the open cell channels or closed cell channels.
Yeah, there are problems according to our understanding of these nanoparticles. If we inject them intravenously, there are few literatures, I can only recall them, that they can stuck to any part of the cells. So we are not sure if we are injecting an intravenous slow infusion or a bolus, they can reach or they can stuck at certain areas depending on the blood flow changes. So, but intraperitoneally, of course, most of them could be localized still within the viscera and can enter into the blood depending on their size and can reach. So we found that intraperitoneal dose is much safer because it is also possible that whatever the small nanoparticles they can have a direct damage to the microvessels intravenously. We have also done some experiments in which intracerebroventricularly we have administered, but the most effects are localized. So therefore, in chronic situations, intraperitoneal administration appears to be much better for us. Of course, one should also do inhalation, but we do not have permission to do this. There are certain laboratories in Netherlands, they are doing for this, simulating the situation of diesel vehicle exhaust. They have special chambers. Our university or our laboratory do not permit this. So we are using intraperitoneal administration of these nanoparticles.
Right.
Yes, sir.
So you said between 50 and 60 nanometers in size. For the silver nanoparticles, the 42 nanometer size seems to be some magic property to it. Have you thought about actually looking at that? Because in other types of damage for skin and other type of ectodermal tissue, the 42 nanometer plus or minus 4 nanometer seems to actually help that tissue quite a bit, but as soon as you get to a higher dose, you end up killing a lot of cells. And you said you're going to talk about maybe this tomorrow, but the two questions are, with silver, how much toxicity did you see? That's one. And with the copper, did you see it interfering with the tetrabiotic cofactor in dopaminergic cells in the brain?
The first thing, working with nanoparticles and size, it's very important and it's very difficult. Because all who are working in the field of nanoparticles, they must know that even the nanoparticles, if they are transported or just stored in your lab for some time, they can change its size. Yeah? Okay. So it is very difficult to differentiate 42 and 50. What we rely, we get the vials from Sigma, they have characterized, and in some cases, preliminary experiments, we did our own electron microscopic investigation. So that's why I said 50 to 60. 40 to 50, 42 to 50 is difficult. So they are in the size range from transportation inside the body, and even they can change its size when they are inside the body. So that's why in our hands, I should say 50 to 60 nanometer, we have a range. I cannot pinpoint 50 plus minus 4, okay? So this is one thing. The other thing is that when copper is in or even silver is in, of course many biological processes are working on them. So many cofactors, many enzymes are changed. But at this moment, our focus is those parameters like blood-spinal cord barrier, morphology. I believe that many changes are occurring in many parts of the body, including skin, liver, but we have not examined them.
Yeah, because I was just wondering with the copper, since your pain system is associated with the dopaminergic system, I didn't know if you were getting attenuation or help from that system to minimize the amount of pain.
No, I understand, but at the moment, our target is not any aminergic system in the brain. Of course, this is a very good idea, but at the moment we are restricted to the spinal cord pathophysiology. Thank you very much. This was a very good question.
All right, thank you. I think we need to move on. Thank you very much.